of the 3rd Annual Neuro-Oncology Symposium. I am Basir Rahman, a medical student here at the Khan University, student organizing committee member of 3 NOS and part of the neuroscience interest group. This is a free paper session, and I would like to begin with introducing our panel of judges for this session. Today we have Dr. Atiq Khan, Dr. Gohar Javed, Dr. Sadaf Altaf, and Dr. Asim Hafiz. Dr. Atiq Ahmed Khan. Dr. Asim Hafiz is a consultant radiation oncologist and assistant professor at Khan University Hospital, Karachi. He completed his MBBS in 2006 from Sindh Medical College and then did FCPS in radiotherapy in 2013. Since then, he has been a part of the neuro-oncology services at AKUH and has been an avid researcher during this time. Dr. Asim Hafiz, please come up on the stage and be seated. Next, we have Dr. Sadaf Altaf. Dr. Sadaf Altaf currently works as assistant professor in the Department of Oncology at the Khan University, Karachi. Dr. Altaf is the program director of the Pediatric Hematology Oncology Fellowship and is the co-chair of Pediatric Oncology for Developing Countries Supportive Care Working Group. Her areas of research interest include bone and soft tissue sarcomas. Dr. Altaf, you are requested to be seated on the stage. Then we have Dr. Gohar Javed. Dr. Gohar Javed is a consultant neurosurgeon and an assistant professor in the section of neurosurgery at the Khan University Hospital, Karachi, Pakistan. He completed his MBBS at Dow Medical University, followed by a residency in neurosurgery at Civil Hospital, Karachi. Dr. Javed's research interests include vascular neurosurgery and spinal surgery. Dr. Gohar, you're requested to be seated on the stage. He's also the head of neurosurgery. Then we have Dr. Atiq Khan. Dr. Atiq Ahmed Khan is one of the top certified neurosurgeons in Karachi. Currently, he's practicing as a consultant neurosurgeon at Civil Hospital, Karachi, and the professor and head of the neurosurgery department at Dow University of Health Sciences. Dr. Atiq Ahmed Khan has advanced medical expertise in neurosurgery. Dr. Atiq Khan, you're requested to be seated on the stage, please. He's not here yet, but he'll be here in a few minutes. I would like to reiterate for the presenters that they'll have 5 minutes to present, after which 2 minutes will be allocated to questions from the judges. To begin with the presentations, I would like to introduce Dr. Muhammad Osman Khalid. Dr. Khalid is an alumnus of the Khan University class of 2020. He completed 1 year of the Dean's Clinical Research Fellowship and is currently a research associate with the AKUH Department of Surgery and academic associate with the Pakistan Academy of Neurological Surgery. As the founding president of the Neuroscience Interest Group, Dr. Khalid has always been a mentor to the students at his alma mater, and his research focuses on challenges in neuro-oncological surgery and LMICs. Dr. Khalid, over to you.
Thank you for that very kind introduction. So without further ado, we'll have our first speaker, Dr. Muhammad Uwais Khan. Dr. Khan is going to be presenting on studying differentially expressed genes in Medulloblastoma subtypes. Dr. Khan, please take the stage.
Assalamu alaikum everyone. My name is Muhammad Uwais Khan. I'm a second-year medical student at Khyber Medical College and research intern at Precision Medicine Lab, Rahman Medical Institute, Peshawar. So the topic is studying differentially expressed genes, which I would refer to as DEGs, in Medulloblastoma subtypes. So Medulloblastoma is a malignant tumor which arises in the cerebellum. Commonly, it is common in pediatric population. There are 4 molecular subtypes of Medulloblastoma, the WNT, SHH, which represent the deregulated pathways, wingless and sonic hedgehog. Group 3 and group 4, they have generalized names because we we don't know what pathways are predominantly deregulated in these yet. So the common presentation of medulloblastoma in clinics include headache, nausea, vomiting, hydrocephalus is very common. And its management is consists of surgery, radiotherapy, and chemotherapy. However, the drugs used in chemotherapy, they are not very specific to medulloblastoma. So the objectives of my study were to determine the genes that were differentially expressed in the different subtypes of medulloblastoma, and then to target those genes computationally with the drugs present in various databases. Okay, so what I did was I went online in search of data set. So there was this one data set, GSE 124814, in the gene expression omnibus, which consisted of 1350 medulloblastoma samples and 291 normal samples. We did preliminary testing of the data set using PCA, which is the principal component analysis. As you can see on the left side of the slide, the clusters in the middle, the samples in the middle are normal in yellow, and around it are the medulloblastoma samples. We added another variable, the subtypes, to see if the clusters of samples around the normal, do they represent the different subtypes? And yes, they did. Next, we did hierarchical clustering of the sample using heat map. On the y-axis, you can see the samples, and on x-axis, the genes, the different levels of expressions of the genes in the cells. Okay, to find out the differentially expressed genes, what we did was we used R, a programming language, to identify the differentially expressed genes in each subtypes. The significant genes was shortlisted using our criteria for significance was an adjusted p-value of less than 0.05 and a twofold change of more than absolute 1. So you can see in this slide, the plots are called volcano plots. The red colors, the dots in red colors are differentially expressed genes in each subtype. This table represents the number of differentially expressed genes in the different subtypes. And on the right side of the slides are the number of common genes, differentially expressed genes in each subtype. Okay, next we wanted to find out what these genes were involved in. So we did an enrichment analysis using David server and found out the pathways for each subtype. And these are the pathways for WNT. As you can see, many cancer-related pathways such as MAPK signaling pathway, WNT signaling pathway, and some pathways are like thyroid cancer, like it has the word cancer in it, so yeah. Same was done for all subtypes. This is for SHH subtype, the group 3 and group 4. Yeah. Now, what we did was we input those differentially expressed genes in a server known as L1000. In order to reverse the effect of those genes, like the ones that were upregulated were downregulated by these servers, and the ones that were downregulated were upregulated. So we got a list of 50 drugs for each subtype that we shortlisted based on its FDA status in Campbell, and overall 19 drugs were shortlisted. So this is the list of 19 drugs and the subtype they were generated for, and its FDA status and the pathways they are involved in. As you can see, Vorinostat was generated for all 4 subtypes, and it is also currently in clinical trial for medulloblastoma. Yeah, a very intimidating slide indeed, but it just contains all the pathways that are involved in cancer. The ones in circle in red are the pathways that we found out by enrichment analysis. As you can see, stars and squares, which represent the number of drugs in our list that target those pathways. So in our study, we found out the drugs which could be helpful in medulloblastoma. However, further clinical studies are needed. So our way forward with it is that do another enrichment analysis using a different server this time, and using and find out the drugs in a different server known as connectivity map. This time we used L1000. Next, we're going to use connectivity map. And we are going to find out the different drug protein interactions using Cytos and visualize them using Cytoscap. And then we're going to test them in vitro in our lab on primarily MB cell lines derived from patients. So these are my references, acknowledgements, and thank you all. If you got any questions, I'll be happy to answer.
I'll just quickly ask you a question. Thank you for the presentation. Were your findings, did you find anything different than what is already established in the literature regarding these findings based on your own search?
So the list of drugs that we found out, it was not specifically for medulloblastoma.
Okay.
Yeah, some of those drugs are FDA approved for neoplasms like breast cancer, but they are not tested on medulloblastoma except for Start. Okay. So we need to establish like that. They work on MB cell lines as well. So these are the things that we're gonna see next.
Okay, thank you.
So it's very nice presentation. So what do you think about the limitation of your study? And
okay, so obviously the L1000 server, it contains only 1000 genes, which represent only 80% of the transcriptomes of the transcriptome. So as I was confused as well that the pathways that the drugs targeted they were not overlapping the pathways that we found out by using David server. So the limitation, which I think is that different data sets are formed, the different databases, they use different data set to form their own, so we cannot say for sure, and this is just a computational analysis. So yeah. Thank you so much.
Thank you, Dr. Khan, for that great presentation. Our next speaker is Dr. Rabeet Tariq. Dr. Tariq is from the Liaquat National Hospital and Medical College, and she will be presenting on the quality of life in survivors of pediatric medulloblastomas, a systematic review.
All right. Good afternoon. My name is Rabeet Tariq, and the topic of my presentation is quality of life in survivors of pediatric medulloblastomas, a systematic review. Okay. So we have no conflicts of interest. Also, we did not receive any funding for the study. For the introduction, medulloblastomas are among the most common pediatric brain tumors. They are the most common malignant primary brain tumor of the pediatric population. And they are categorized based on the molecular subgroups, and each molecular subgroup has a different epidemiology. They're primarily a cerebellar tumor, and the further epidemiology and further location depends on the molecular subtypes. The molecular subtypes, as defined in the previous presentation, are for WNT, which are mainly in the cerebellar peduncle, then sonic hedgehog or SHH in the cerebellar hemisphere, and group 3 and 4 are usually in the midline of fourth ventricle. So the clinical features are, they vary a lot, and they are usually gradual. Mainly the clinical features are because of hydrocephalus and vomiting. They may be visual disturbances because of papilledema. In children, in younger population, they may present with behavioral disturbances. And because they're primarily a cerebellar tumor, they may present with ataxias. So because they are a malignant tumor and they have a poor prognosis, so there is an intensive treatment which consists of a maximal surgical resection, followed by chemotherapy and radiotherapy. Chemotherapy is optional. and is not done in a few cases, but radiotherapy usually is done in most of the cases. And in our setup, like in LMICs in Pakistan, we do craniospinal radiation or conventional radiotherapy. In other developed world, there is a proton radiotherapy which is used. So since it's a poor, since a young age and a posterior fossa tumor and an extensive treatment or radiation is associated with a poor prognosis, it may be related to a poor quality of life in the survivors. So the objective of our study was to analyze the quality of life in the survivors of medulloblastomas, and to analyze which factors actually lead to a poor or a better quality of life outcome. So we used the PRISMA guidelines as a method, as a template for our methodology. We included all the case control, longitudinal cohorts, cross-sectional studies. We excluded case reports, case series, and the articles which did not specify medulloblastomas. We used Zotero software for the data analysis, and risk of bias assessment was used during using these stroke guidelines. This is our PRISMA flow diagram. We assessed 54 articles, out of which full articles were assessed, which were 19, and 12 of them were included in our study. So these are the demographics of the included studies. The studies in which we have MB written were not exactly specified to medulloblastomas, but they had medulloblastoma in their populations. So these are the quality of life outcomes. To summarize our results, all of the studies which assess the quality of life actually reported a compromised and a poor quality of life in the survivors of the tumor. And another thing that the proxies or the caregivers usually reported a comparatively worse quality of life as compared to the survivors themselves. And only one study assessed the different molecular subtypes and reported that there's no significant differences in the quality of life in the survivors. Further, we could not do a quantitative analysis due to the differences in the scales used to assess the quality of life. However, as many as some studies which used proton radiotherapy, and some studies used craniospinal radiation, and the PEDS-QL scores were not very different. Therefore, the people who were treated with conventional radiotherapy and those who were treated with proton radiotherapy might not have different outcomes. Then the factors that were associated with a poorer outcome, quality of life outcome, were disease severity, metastatic disease, a lesser age at diagnosis, a current lower IQ, lower socioeconomic status, and hydrocephalus at the time of diagnosis. So basically, medulloblastoma survivors are at high risk of developing cognitive, behavioral, and emotional problems, which further lead to socioeconomic, social, and physiological decline of these patients. Therefore, their social functioning has been compromised. They do not have a normal, healthy lifestyle, as well as they're not fit for many of jobs which may be there for normal populations. Then there may be a gradual progressive betterment in the quality of life scores. However, this was not significant in any of the studies. So intellectual function is also decreased. Therefore, they cannot be doing specific jobs. The limitation of a study is that we could not do a quantitative analysis due to differences in the study, the scales that the different studies used. Further, that every study analyzed a different subgroup of this quality of life, such as, for example, some studies did not specifically mention the cognitive outcomes, and some did not mention the physical outcomes. And some studies were not specified to medulloblastomas. However, they did have medulloblastomas in their populations. So basically, medulloblastoma survivors need to have a different form of physical and psychological therapy in a long term after their recovery. Thank you. I would be glad to answer any questions. All right, thank you.
I do have a question. So the studies that you chose, were these all across the different socioeconomic sort of nations, or was it limited to high income countries versus low middle income setting versus low income countries? What was the sort of uniformity in terms of the distribution?
Among the 12 studies, only one was from India. One was from South Korea. Rest of the studies only assessed the American and the European populations. Also, there was one study which was a multinational study, and but most of the countries were developed countries in that study as well. Thank you.
Thank you, Dr. Abid. Our next speaker will be Dr. Ahmed Nasir Beg. Dr. Beg is from the Aga Khan University Hospital, and he will be presenting on the comparison of minimally invasive and open surgical approaches for intradural extramedullary spine tumors. Dr. Beg.
Good afternoon, everyone. I'm Dr. Ahmed Nasir Beg. I'm resident PGY5 in Department of Section of Neurosurgery at AKUH. Thank you, Sman, for the introduction. So today I'll be presenting comparison of minimally invasive and open surgical approaches for intradural extramedullary spinal tumors. It is a systematic review and meta-analysis. I have no financial interest, affiliations, or arrangements that would constitute a conflict of interest. So as you all know, that spinal tumors can be broadly classified into their location, that is intramedullary or extramedullary. So we will be discussing the extramedullary part. In extramedullary tumors, there are more common tumors which comprise of nut sheath tumors, meningiomas, and myxopapillary ependymomas. However, the less frequently encountered tumors are hemangioblastoma, lymphoma, metastasis, paragangliomas. So intramedullary tumor, intradural extramedullary tumors comprises of almost 70 to 80% of all spinal tumors. However, spinal tumors itself comprises of almost 5 to 10% of all CNS tumors. The most common tumors which are encountered in intradural extramedullary location, as I've already spoken, are meningiomas, nerve sheath tumors, which include schwannomas and neurofibromas. However, myxopapillary ependymomas can be encountered are usually encountered at the phylum terminal. These are usually benign and slow-growing tumors, so the presentation is quite a long time after the initial development of these tumors. Conventionally, these tumors are surgically resected via open approach via posterior midline incision that is combined via laminectomy or multiple level or single level laminectomies depending on the extent of the tumor. And this exposes the spinal canal, providing adequate exposure for the excision of these tumors. However, this conventional approach has some difficulties and some postoperative complications. Firstly, it causes pathological and biomechanical abnormalities in the patients in long term. These are due to the destruction of the dorsal bony structures, the ligaments that are involved, which are removed during open approaches, and the stripping of paraspinal muscles. In recent past, minimally invasive approaches have been more prominent, and they have been advocated to approach these tumors. This includes a smaller incision size. However, the incision size does not define the approach as minimally invasive, as these can be larger incision size, but the amount of tissue that is being extracted or removed, the amount of normal tissue and the ligaments that has been removed in these surgeries, that is what classify these as minimally invasive surgery. So in most of these minimally invasive surgeries, ligaments and bony structures and the paraspinal muscles, they remain intact. Currently, there is no level 1 guideline or evidence for preference of approach towards these spinal tumors, and there is no previous meta-analysis or systemic review to ascertain the superiority of minimally invasive versus the open approaches. So the objective of this study was to evaluate surgical, functional, and complication-related outcomes in patients who were undergoing spinal surgery via minimal or open approach for intradural extramedullary tumors. So after registration with Prospero, we did a search on PubMed, Senahil, and Cochrane Library from conception until January 2022. We included all those studies where there was a cohort comparing both the patients group undergoing minimally invasive or open approaches. However, we removed studies where there was no comparative data, or these articles where the adult populations, the data could not be extracted. So our patients were the patients, or our population was the patients who had intradural extramedullary tumors, and there was a comparison made between the open spinal surgery approach via the minimal or versus the minimally invasive approach. So we divided our outcomes into primary and secondary, and our primary outcomes were surgical factors that were included are blood loss, operative time, the extent of resection, post-operative complications such as the formation of pseudomeningeal infections, CSF leak, length of stay, reoperation rates, and cost. However, secondary outcomes included intraoperative complications and progression. So this is the Prisma chart showing that on the initial search, we found that there were 403 articles. However, after removing the records and for duplicates, we were left with 395 records. However, upon further going through these records, we found that only 13 studies could be used for quantitative and qualitative analysis. So statistical analysis was done using the Revman version, and pool participant data was included in a random effects model, and heterogeneity of subgroups were calculated using I2 statistics, and I2 of more than 40% was assumed to represent significant heterogeneity amongst the groups. So after systemic review and exclusion, 13 out of 403 studies were included for qualitative and quantitative analysis. So these are the number of studies, and they show that the sample size was adequate in both in all of these studies, and they had mean equal ages and genders for their inclusion in the study. So on the review of bias, so we found that almost 8 out of 13 studies, they were of good quality, and 2 were fair and 1 was poor quality study. On the results, we found that the extent of resection was not different in either of the arm, either minimally invasive or the open surgical technique. So the p-value here was 0.078, which was not significant. So there was no significant difference between the gross total resection achievement in either of these arms. And this is applicable to general population because we see the heterogeneity in this result was 0%. Intraoperative blood loss, however, was significantly less in the minimally invasive arm as compared to the open surgical arm. Same was the case with the operative time, where the p-value was 0.04. It was lesser in the minimally invasive arm. And length of hospital stay was again 0.001 in the minimally invasive as compared to the open surgical techniques. So the rate of complications that we found was not significant for any of the complications that were reported in these studies. There were 5 cases where there was CSF leak in open surgical technique, and 10 cases where there was CSF leak in minimally invasive technique. However, this was not significant. These studies almost completed all of these studies almost completed their follow-up until at least 2 years with post-operative MRI. So these were good quality studies. So in conclusion, I would like to conclude that minimally invasive surgical approaches are as good as the open surgical approach for adequate resection of intradural extramedullary spinal tumors. And these are better than the open approach due to less intraoperative time, less intraoperative blood loss, and postoperative complications. So the limitation of my study was there were no prior clinical trials that could be included. There was limited studies, only 13 studies was included. However, the strength of this study was that All these studies were from different ethnicity and different parts of the world which were included. And on the results, we see that intraoperative blood loss, length of hospital stay, and operative time, even though it was significantly less in the minimally invasive arm, there was a significant heterogeneity among the groups, so thus requiring more studies for this. So my acknowledgements to Dr. Faiza Uruj, Dr. Hamza Bajwa, and Dr. Shehzad Shami. Thank you.
If anybody wanted to ask any question, this is a question answer session. You may ask.
Dr. Hammer, it was a good study and good presentation. Have you compared the neurological outcome of the minimally invasive and open techniques?
Thank you for Dr. Gohar for the question and the comments. So we could not compare the neurological outcomes as these were reported in very few of these studies, as we can see, and there was no significant difference. Only 3 studies reported that there was persistent weakness, or there was in 2 studies there were reoperations due to neurological worsening. However, they did not specify if this weakness was transient or permanent.
Dr. Hammer, very nice presentation. One of the questions is because in on initial search you have found more than 400, but then limited to only 13 studies. So what was the reason of not including all those things? Number one thing. The other thing is that one of the findings is that the irrespective of the whether it is open or the minimally invasive, the gross total resection rate would be the same. So how many studies actually address this question? That technique would not actually translate into the cross total resection, or does not have any relation with the cross total resection.
Thank you, Dr. Asim, for these questions. So for the first part of your question, so initially there were 403 studies. However, upon review of the duplicates, we removed 8 studies. We then were left with 395 studies. However, upon reading their title, their language, and the availability of abstracts, we removed further 376 studies. And in these were the studies that those were case reports, case series, and there was no comparative data that was available. So that's why we excluded these studies. As to the second part of your question, sorry, can you please repeat the second part of the question?
Impact of techniques chosen on the gross total resection.
Okay, because most of these cases were most of these studies were retrospective cohorts, so there was always a bias of surgeon's choice towards going either minimally invasive or open surgical technique. However, there were few studies to exclude this bias. They set up a marker that tumors of more than 2 or 3 centimeters were chosen from each of these studies, and then they were assessed if their intraoperative blood loss and all these were same or different. They always found that the minimally invasive results were better than the open surgical techniques. In some of these studies, they had to remove these bias. There was regression curves analysis done to remove this bias. Thank you.
Thank you.
Thank you, Dr. Emmer. Our next speaker will be Dr. Kainat Siddiqui. Dr. Siddiqui is an academic associate with the Pakistan Academy of Neurological Surgery, and she will be presenting on outcomes following CyberKnife robotic radiosurgery for functional and non-functional pituitary adenomas. Dr. Siddiqui.
Thank you. Good afternoon, everyone. So I'm Kana Siddiqui, and today the topic of my presentation is outcomes following cyberknife robotic radiosurgery for functional and non-functional pituitary adenomas. So there are various treatment modalities for pituitary adenomas, with surgery being the gold standard. But among the different modalities of the stereotactic radiosurgery, cyberknife radiosurgery is the most advanced one that uses robotics to deliver its radiosurgical dose in a frameless fashion without any skull fixation and discomfort, and with sub-millimeter accuracy. Previous studies have shown favorable outcomes of the cyberknife stereotactic radiosurgery with regard to tumor reduction, tumor stabilization, vision preservation, and neuroendocrine control. However, these studies were limited to smaller sample size and short-term follow-up. Therefore, we propose to conduct a single-centered study at the Department of Cyberknife Robotic Radiosurgery, JPMC, to assess these outcomes in a larger patient population. The type of study was a retrospective cohort 1 comprising of 277 patients. So we assessed, we included the selection criteria for the pituitary adenomas at our center was the histological or the MRI diagnosis of the pituitary adenoma, the residual or the recurrent lesion. There should not be any increase in the ICP of the patient, and the patient who have previously refused surgery or who are not the good candidates of surgery. This is done after the meeting with the neurosurgeon. The outcome measures we wanted to assess was to monitor the radiological control of the tumor, to assess the hormonal control in functional adenomas, to assess effects on perimetry post-cyber of the affected individuals, and to evaluate any possible SRS toxicity and the risk of developing delayed hyperpituitarism post-treatment. So we categorize these adenomas into two types that were the non-functional adenomas and the functional adenomas. The non-functional adenomas were in greater number, that is 168 cases, whereas we had 109 patients in functional adenomas. These functional adenomas were further classified into three classes. There was the growth hormone secreting adenoma, ACTS secreting adenoma, and the prolactinoma that were refractory to the medical treatment. The growth hormone secreting adenoma were a greater number of population, that was 89 cases. So we had more females than males in our study, that is 60% females and 40% males. The mean age was 40 years, approximately 40 years, with the range between 8 to 79 years. The mean duration of follow-up was 16.8 months. So we had the at our institution, we had the criteria of follow-up for the non-functional at the initial most follow-up after the cyberknife radiation was for the non-functional adenomas was 6 months. And for functional adenomas, it is for the 3 months. The investigation that we need at the follow-up are the perimetry, the MRI brain with contrast with pituitary protocol, and along endocrinology profile in especially functional adenomas. There has been 84% of the patient presented with history of previous surgery at the time of presentation at our center, and 30.6% presented with SRS hormone deficiency before the treatment. The radiosurgery dose for non-functional adenomas is 25 grays into 5 fractions, and for functional adenomas, it is 30 grays into 5 fractions. These fractionation is done to increase the normal tissue tolerance so that minimal toxicity occurs. So at the time of presentation, we had the endocrinology profile and the perimetry and the MRI before starting the cyberknife treatment. So 227 patients among the 227 patients out of 277 patients presented with the affected perimetry and decreased visual acuity. Post-cyber treatment with 16.8 months of follow-up, we saw that 61.7% of the patient presented with improved perimetry. However, 15.4% had no change in perimetry, whereas a significant number, that is 22.5%, did not present with perimetry at the follow-up. Only one case had a deteriorated perimetry. So at a mean follow-up of 16.8 months, we also assessed the tumor size on MRI brain. That was reduced in 212 cases, and no change in at least 14.8% of the cases, whereas 8.6% of the cases lost to follow-up. As we had a greater number of people in growth hormone secreting adenoma group and 17 cases in the ACTS secreting adenoma group, so the hormonal outcomes were seen. That is, approximately half of the patients in the growth hormone secreting adenoma group had a hormonal profile that was in a reducing pattern, whereas 28% in this group underwent into complete remission. In ACTS secreting adenoma group, 41% of the patient went into complete remission, whereas 35% had a reduction in hormone. There are also 13% and 17% of the people that did not had an endocrine follow-up, and therefore we had counted as a loss to follow-up in this area. So the mean period for complete remission was also assessed at from the time of cyber till the report that had that showed the complete remission of hormones, the last follow-up. In growth hormone secreting adenoma group, it took about 21.1 month, whereas in the ACTS secreting adenoma group, it took about 17.7 month. In the 3 cases of the medically refractory prolactinoma, all the 3 cases had a reduced prolactin in the follow-up. So we also assessed the post-CKSRS toxicity at the time of follow-up, and it was seen in 2%, that is 6 cases. This toxicity occurs any new onset sensory or motor deficit that is very minimal also, but 2 patients had a new onset trigeminal neuralgia. There was also as new onset pituitary hormone deficiency post-cyber treatment was also seen in 26 cases, whereas 52 cases failed the endocrine follow-up and did not present with these reports. There were significant limitations that a longer follow-up is still needed. The study was retrospective and single-centered, and thus there cannot be any generalizability. And significant number of cases lost the follow-up in different areas of our outcomes. Therefore, to conclude, I would say that to compare the clinical, hormonal, and radiological outcomes of pituitary adenomas, we conducted this study and highlight the SRS complication in a greater patient population. And we observed that there was a 76.5% of the reduction in tumor size, good hormonal control in growth, especially in growth hormone. Secreting adenoma significantly improved perimetry and minimal post-CK neurotoxicity. Moreover, biochemical reduction and remission was also observed in the functional adenomas. Thank you.
Thank you, Dr. Kainat. It's really a very wonderful study as far as the cyber life is concerned, and regarding the pituitary tumor surgical versus this gamma knife, this cyber knife treatment. My question to you is that I think some 2% of the patients are ACTH secreting tumors in your study, and they are the secretory tumors. And if talking about the cortisol secreting tumors, it's most of the time they are so small in size that you cannot visualize, even you cannot pick up them on MRI. So my question to you is how you, because there is 2.2% neurotoxicity when you, it's seen in your study, it's very obvious after cyber knife, 2.2% patient present with neurotoxicity. So, in ACTH secreting tumor after the growth hormone, because these are the second most commonest tumors in your study, they are not visualized on MRI. So how you proceed and what is the modality of giving a cyber knife radiation in such type of cases?
Thank you, sir, for the question. So the radiation oncologists at our center usually give the cyber knife radiation at the areas of the pituitary area. They are usually microadenomas. I have not added the macro and the micro category here, but yes, you are true that most of the microadenomas were present in these ACTH secreting adenomas. So they are radiated at the pituitary area. And we had a strict follow-up and a strict pre-CK, the hormonal profile of these patients.
Okay. So nice presentation. You have mentioned about the mean duration of follow is 16.8. What are the interquartile range of the of the follow-up period. Number one thing. The other thing is we also mentioned about the toxicity associated with. But so what are the common toxicity that you have observed in your study after post cyberknife?
So, sir, our follow-up for the pituitary adenomas are is for the initial most for the functional one is at the 3 months. And the last we had the maximum of about 4-5 years. The range is between the 3 months to the 5 years. And can you please repeat the second question?
You mentioned about the side effects post SRS about 2.2%. So what are the common toxicity that has been observed in your study? And that's the question.
So 2 cases among them were presented with the trigeminal neuralgia. 2 cases presented with the sensory deficit, and that was on the facial area. And other 2 had the sensory deficit at the temporal area.
Dr. Kanad, good presentation. You had these 85 patients who had panhypopituitarism before SRS, and there were how many cases? 50 odd cases who had new onset of panhypopituitarism. Have you compared that 52 cases or sorry, 26 cases? So have you compared this? Because when you say remission, then this remission may be just an initial manifestation of panhypopituitarism. And if with long follow-ups, one may see more cases of panhypopituitarism with these so-called remissions after SRS. Have you compared it with any of the other studies?
Sir, actually, we are in the process of comparing these groups, but as the endocrinology profile is sometimes missing because at the follow-up for the endocrinology, we need to get either it is a secreting or a non-secreting. We had to get the whole endocrinology profile, that is TSH, FSH, TSH, testosterone, and everything. So sometimes the patient present with less follow-up, and therefore we have to call, due to bias to exclude the bias in the study, we had to cause them to the lost follow-up. But we are in the process of comparing it, and still analysis is going on in different areas. Thank you.
Thank you, Dr. Siddiqui. Our next speaker, before we move on to our next speaker, can I please ask if Dr. Fahimullah Khan is present? Okay. So our next speaker is Dr. Mehjabeen Memon from the Liaquat University of Medical and Health Sciences. Her presentation will be on paraparesis in a 12-year-old boy, a case report of benign fibrous histiocytoma involving dorsolumbar spine.
Bismillahirrahmanirrahim. Assalamu alaikum and a very good afternoon, everyone. I am Dr. Mehjabeen Memon. I have completed my residency at Liaquat University of Medical and Health Sciences under the supervision of Professor Riaz Raja, and I'm truly humbled to be presenting my little piece of work in front of the giants, and I hope that I'll be able to deliver it properly. So it is a case report of a paraparesis in a 12-year-old boy, and the histopathology came out to be a very rare tumor, that is benign fibrous histiocytoma. So to begin with, benign fibrous histiocytoma is a very rare tumor, and in the entire world literature, 17 cases of benign fibrous histiocytoma involving the spine have been reported. It is very commonly involving the extremities, the pelvis, but only 17 cases have been reported in spine. And out of those 17, only 4 cases have been seen among pediatric patients. So it is very rare. So this is a table which was published in a study in 2016, and we can see that here, sorry. Yeah, we can see that It is comprising of 12 cases because it is up till 2016. There have been more cases after that. But the important thing which we can see is that only like this 13-year male, 6-year male, and 14-year male, only out of these 12 cases, 3 are of pediatric age group. So it is very rare to see this tumor in pediatric patients in spine. Though it is a benign tumor, but it has a tendency to invade the nearby structures, and usually the clinical presentation and the radiological findings are deceiving, and the histopathology is the only thing by which we can confirm this. Surgery is the mainstay, and literature usually shows satisfactory outcomes. So now we present a case of this rare tumor in a 12-year-old boy who presented with paraparesis. So he presented with weakness of both legs since 8 months, and there was no significant history of trauma, no significant past medical or surgical history. On examination, the power was normal in both upper limbs, and in right lower limb, it was 2/5 at all joints, and in the left lower limb, it was 1/5 at all joints. The reflexes were normal, plantars were bilateral mute, and sensory and sphincters were intact. So we carried out CT scan, dorsal lumbar spine and abdomen with contrast. And here we can see that this is a soft tissue density lesion, which is involving the neural foramen at the level of L1 vertebra. It is going into the paravertebral space, involving the paravertebral soft tissues, compressing the kidney, also going into the canal and compressing the spinal cord. Here we can see this tumor, which is involving the D12 and L1 junction, and it is also destroying, we can see here, it is also destroying the vertebral body. We carried out the MRI scans, and this lesion is appearing iso to hypointense on T1, hyperintense on T2. These are the axial cuts of T2, and we can see this characteristic dumbbell shape, which we were deceived at the time when we saw it, this dumbbell shape, and we were like thinking it of as a neurofibroma. And on contrast, it showed heterogeneous enhancement. We can see how diffusely it is involving the paravertebral spaces and paravertebral muscles and compressing the right kidney to the opposite side. So on the basis of the clinical presentation and radiology, the top 3 differentials made were of neurofibroma, Ewing sarcoma, and osteoma. This case was discussed in pediatric tumor board, and these were the 3 top diagnoses that we came up with. So we went for surgery. We confirmed the D12 and L1 levels by fluoroscopy intraoperative, and we made an incision between D11 to L2. When we opened the paravertebral tissues, we saw the part of the tumor in the paravertebral and postvertebral tissues, and we excised it. Then we did D12 L1 laminectomy, and the extradural part of the tumor was seen. It was soft, suckable, grayish in color, moderately vascular tumor, which was safe, totally resected. And we sent the biopsy, and we closed the layer skins. We closed the skin in layers. The post-op recovery was uneventful, and the patient significantly got better. His neurology improved right by the 3rd or 4th post-op day, from 2 in the right lower limb to 4+, and 1 in the left lower limb to 4+. So that was a significant, and on follow-up, the patient came after 1 week. The patient was actually walking without support. Now, we were expecting those 3 differentials, right? But when the histopathology came up, it showed typical findings of benign fibrocystiocytoma, the spindle-shaped cells and storiform appearance, the focal positivity for S100, the scattered histoid and multinucleated giant cells in between. So these are the histopathological pictures, which shows the storiform appearance, the blend tumor cells, and the focal positivity for the S100. So this is a mere repetition. A few points I want to make that are different in our case is that usually clinically the patients present with non-specific low back pain or back pain wherever it is involving the spine. But in our case, the patient presented with paraparesis, which is rare. So that's one thing different in our case. The other point is that the scans usually show that the paravertebral tissue is not significantly involved in benign fibrocystiocytomas, which is not in our case. In our case, the paravertebral tissues were significantly involved. For example, this is one of the case reports published in 2009. It's of a 21-year male, in which we can see that the tumor is an expansile lesion which is involving the vertebral body, pedicle, lamina, and the transverse process, but it is not involving the soft tissues, as we can see on the MRI. On the contrast, this is our case, and in which we can see that it is diffusely involving the psoas muscle and the paravertebral structures. This is another case of an 11-year-old boy. Again, we can see that the tumor is confined to the bony structures, but here, this is again the MRI, which is showing that the tumor is confined, but in our case, it was involving soft tissues. And again, histopathology is the gold standard, and all of these typical findings were seen in our case. And surgery is the mainstay. Because it's a rare tumor, there are not much recommended guidelines, but though it is said that the surgery, safe total resection by posterior approach with or without fixation is the mainstay, and usually prognosis is good with minimal recurrence, or like literature says that there is no recurrence rate. So it's a very rare tumor, 17 cases involving spine, only 4 pediatric cases. Maybe this is 5th case which we are reporting, and it has a very good prognosis with nearly no recurrence rate and very good significant post-operative outcome in long run. But we need to follow this patient as well, so that we can see what actually long run results are of this tumor. So these are the references. Thank you. If there are any questions, I'm happy to take.
Thank you, Dr. Mahjabeen. Just a few observations. I hope I have not missed. Have you shown any post-op scans? Oh, you haven't.
No, I did not, because
Okay. And
yeah.
the other observation was that you told us that there are 17 reported cases, aren't they?
Yes, sir.
And but in your references, you have quoted only 5 of them. If I can comment that if it is a benign tumor, the optimum treatment for most of the benign tumors is surgery, surgical resection. Have you taken out the paraspinal part of the tumor also?
Yes, sir. Thank you for your question. The first part of the question is that I have mentioned only 5 references. The reason is that the time it was first diagnosed, the first case report was in 1980. Since 1980 till date, there have been 17 cases in the spine that have been reported in literature. So I just mentioned the recent papers around last 5 or 7 years. I did not mention the papers which were published back in 1980s. So that's why my references are only 5. The other question is that, yes, we did take out the paravertebral when we opened, when we went through the posterior approach, we saw the tumor in the paravertebral tissue. We excised it, and then we did laminectomy, and then we excised the extradural part of the tumor. Hope this answers the question. Thank you.
Dr. Tala, you wanted to ask something?
Dr. Gohar has already asked for post-op image. I forgot what was the age of the kid.
12 years.
So you have removed pedicle and flexor joint. Any fixation was required?
No, not like we didn't find the intraoperatively, we did not find it necessary to go for fixation.
It's at the thoracolumbar junction.
At the thoracolumbar junction, yes.
So you think no fixation was required?
The literature says you can do with or without fixation. It's the surgeon's choice. So at that time, the primary surgeon did not think it was necessary, so we didn't go for fixation at that time.
No, fair enough.
Thank you.
I think he's a 12-year-old child, so probably they were thinking of follow-up, and later they can, if they find anything. But yes, it's a very important question from Tala. But this is a dorsal lumbar junction, and there's a highly likely chance of instability, and if you remove the pedicle, because there are, yes, it's a good question, I think. I think they need to follow up with this. Apart from this, I just need to ask that most of these fibrocystocytomas are orbital mainly, and spinal are very rare. And your biopsy, you have done 2 cases. Your histopathology reveals most of them are benign, or they show some malignant, changes in your study, please?
Benign, sir, as such, because the typical findings of mitotic index was less than 5% mitotic figures in the high power field, so benign. Thank you so much. Thank you.
I just have one quick question. Considering the rarity of this tumor, was a second opinion sought on the histopathology?
No, I don't think so. It should have, yes.
Thank you.
Yes, thank you.
Thank you, Dr. Majbeen. Our last speaker will be Dr. Adil Qamar. Dr. Qamar is from the Ziauddin University, and he will be presenting on central neurocytomas, research trends, most cited papers, and scientometric analysis to date. Dr. Qamar couldn't be with us today, but we have his recorded talk.
Assalamualaikum, my name is Mohammad Adil, and I'll be presenting study titled Central Neurocytomas, Research Trends, Most Cited Papers, and Scientometric Analysis to Date. And these are my fellow co-authors. To the right side, this is a figure which was created by the analysis of the author keywords which were analyzed from our included articles. So central neurocytoma was described as its own entity in 1982, and thereafter, after 4 decades, there is still debate over the treatment and management of this particular pathology. Hence, this bibliometric analysis was conducted in order to study the trends, research trends related to central neurocytoma. We screened the Elsevier Scopus database on January 2022. We used the following keywords and the following inclusion criteria. We extracted the following parameters, which were article title, year, authors, citations, country, institution, keywords, etc. And our analysis was conducted on R version 4.1.2. So this is table 1, which summarizes the characteristics of the data set. A total of 1,002 articles were included in our analysis, and the average citations per document was observed to be 19.67. As far as publication types is concerned, so article accounted for 80.1% of the total types of publication. And as far as collaboration is concerned, so the collaboration index was observed to be 4.21. So table 2 shows the summary of the 10 most cited articles relevant to central neurocytoma, where Hossain et al. Study central neurocytoma and electron microscopic study of 2 cases top this chart. We can observe from this table that a shift was seen from basic sciences to clinical sciences with regards to central neurocytoma. Also, you can observe that most of these studies are quite old. This can be explained from the fact that older studies have been present in the scientific literature for more time compared to newer publications. Hence, they have a greater chance of acquiring a greater number of citations compared to their newer publications. So table 3 shows the top 10 journals by number of articles, where Journal of Neuro-Oncology topped this list with a total of 43 articles. Most of the journals which were included in our study had an impact factor less than 10. This can be explained by the fact that lower impact factor journals have a shorter waiting time and a higher acceptance rate, plus the procurement of funds to publish in a high impact factor journal are one of the reasons which can explain this trend observed. Coming to table 4, so this was the top 10 most cited countries with average article citations, and USA topped this list with a total of 5,588 citations. Switzerland had the highest average article citations, which were 108.5. This can be explained by the fact that, as we can observe in this table also, that most of these countries are developed nations, So developed nations have a higher budget for their research compared to developing nations. Hence, this trend was observed. So in our analysis, we observed a shift from histopathological and clinical symptoms towards the treatment and management of this tumor, where the future researches will be driven towards. As is the case with any other study, our analysis was also prone to some limitations, which have been highlighted in this slide. And the authors recommend that future bibliometric analysis should take into account these limitations so that a more robust analysis is produced in future. Thank you.
Thank you, Dr. Adil. Dr. Adil is here with us on Zoom if there are any questions.
If there is any question from the audience, they wanted to ask any question. So this is the first bibliometric analysis of these intraventricular tumors. So what's your take on this? Do you think that this study need to be, this analysis should be conducted in a broad spectrum, or is it possible because it's a bibliometric analysis? Can you explain this?
So, yes. So one of the limitations which wasn't written in the slide was that we only went through one database. So if in the future studies, more databases should be screened so that the range of this analysis is further broadened further. Yes.